on a tangent, but as long as we're here talking about bleeds versus clots, what are some of the major risks for bleeds? I mean, I know some people out there have genetic predispositions for being bleeders, as they're sometimes called, or clotters. So things like factor V Leiden mutations, which can be exacerbated in women, for instance, by taking certain oral contraceptives. I mean, and there's huge lists. If people are interested in them, they can look up, what are the factors controlling bleeding and predispose people to being clotter. But for the typical person out there who feels healthy, but might do well to know whether or not they are predisposed to be a bleeder or a clotter, what sorts of things rise to the top of that list and that people might want to check into?
Well, I mean, there might be sort of two different things going on in that question. But I think if your question is, when we look at the subset of people who are at highest risk for hemorrhagic strokes, the far more germane question is not underlying coagulopathy. The far more germane question really comes down to blood pressure. Blood pressure would be the first, second, and third driver of that. So hypertension is hands down the leading driver of hemorrhagic stroke phenomenon.
Okay, so I'll just briefly interrupt and ask, since sometimes your recommendations deviate from the standards that one would find online or in the typical doctor's office, at what point do you get concerned?
Well, I actually find myself quite in line with the most recent available data on blood pressure. And this has been, obviously, this is a topic that's of high concern to any doctor who's taking care of patients, who even pays a fraction of attention to the available literature, which is that basically with each subsequent blood pressure trial, the data are becoming clearer and clearer that the more aggressively you manage blood pressure to be within the 120/80 range, the better. So, there's a recent study that even looked at going from what used to be considered acceptable, which was 130 to 135 over 80 to 85. We used to basically say that's kind of the first level of hypertension. And we would say, well, do you really need to be better than that? And the answer turns out to be yes, you do. If you want to reduce heart attacks and strokes, it's better to be 120/80 than 135/85. Now, this is a whole other rabbit hole that we don't need to go down, but it's a total obsession of mine, which is how do you measure a person's blood pressure? I think this is potentially, I'd have to give it thought, but honestly, I could say top 3 underdiagnosed fixable problems in the United States today and probably globally. In other words, there are too many people walking around with high blood pressure who don't know it. And I think part of the problem is it's something that is mostly done in the doctor's office, and the readings that you get in the doctor's office can be often misleading. You've heard of this phenomenon of white coat hypertension. So you go to the doctor, your blood pressure is virtually never measured correctly in the doctor's office.
That cuff they put on and that little squeeze bulb, that's not accurate.
If you look at the rigor with which you need to measure a person's blood pressure, the right way to do it is the person has to be sitting like this for 5 minutes doing nothing.
Okay, folks. So when you go to the doctors now, you don't let them take your blood pressure
out of the
gate.
gate.
Sitting for 5 minutes, and that doesn't include in the waiting room, because if you walk
because
from
then
the
you
waiting
get up
room,
and walk over, right?
Okay, so make them stand there.
Right. So you want to be sitting there like this. A manual cuff is better than an automated cuff, but not enough people use manual blood pressure. So a manual blood pressure means they put a cuff on you, and they actually put a stethoscope on the brachial artery, and they're using the human ear to listen, which, believe it or not, you would think a machine is better, but it's not. The machine can be misled by different sounds. Now, I don't want to suggest that automated cuffs are useless. They're not. But when an automated cuff gives you an answer that is, potentially suspect, always back it up with a manual. I'm pretty relentless about checking my blood pressure. And so I'll do side-to-side manual versus automated every day. And there's easily a 10 to 15 point difference between them.
Maybe this is a silly question, but can people check their own blood pressure?
Meaning manually?
Yeah, just could I get a cuff and a bulb and learn how to do it?
Yeah, I think so. I mean, I can do it, but honestly, I usually have my wife do it. She's a nurse. But it's not rocket science to check blood pressure. I guarantee you there's a great video on YouTube that explains the physiology of it. And if you're willing to splurge on a good enough stethoscope and cuff, the cuff I have is really easy to use. Like, it's, once you put it on, it's in a single thing. I'm squeezing the bulb and looking at the pressure gauge while I've got the, stethoscope on my artery.
I mean, given the importance of